Nursing care of serious mental illness across the continuum. Module 2, Community Mental Health and the Recovery Model. When we move from acute stabilization to long-term management, we shift our lens outward, from hospital-based care to long-term management in the community. When we move beyond stabilization, we enter the world of serious mental illness and the community mental health system. This is where recovery truly unfolds. In this module, we will explore how community-based services support individuals living with SMI and how nurses play a central role in helping patients build meaningful, self-directed lives beyond the hospital setting. Serious mental illness, or SMI, refers to persistent psychiatric conditions such as schizophrenia, schizoaffective disorder, bipolar disorder, and severe major depressive disorder that significantly impair functioning. These are not short-term conditions. They often require lifelong, coordinated, multidisciplinary care. Approximately 5% of adults in the United States live with SMI, and this population experiences disproportionate disability, reduced life expectancy, and high healthcare utilization. Individuals with SMI often struggle with employment, housing stability, relationships, and self-care. This is why long-term, community-based support is essential. Community mental health systems were developed to move care away from long-term institutionalization and into community-based treatment. Each county has its own CMH authority, and eligibility for services typically requires enrollment in the state Medicaid program. CMH agencies provide structured outpatient services, psychiatric medication management, crisis stabilization, partial day programs, community-based alternatives to hospitalization, and active case management for individuals with SMI and dual diagnoses. Some patients may qualify for assertive community treatment, or ACT, which provides intensive team-based care in the community. The goal is simple: provide care in the least restrictive environment while promoting stability and community integration. Many individuals in CMH live with dual diagnoses, meaning they experience both a serious mental illness and a substance use disorder. Dual diagnosis increases relapse risk and requires integrated treatment. Beyond diagnosis, social determinants of health profoundly affect recovery. Housing instability, unemployment, transportation barriers, stigma, poverty, food insecurity, limited social support, and difficulty navigating complex systems all influence outcomes. Many individuals with SMI have limited financial and cognitive resources, making system navigation extremely challenging. Addressing these barriers is just as important as providing medication. It is important to recognize that many individuals with SMI live at home with parents or extended family rather than in structured residential settings. While this can provide stability, it can also lead to caregiver burnout. Families often coordinate appointments, monitor medications, manage crises, provide transportation, and offer emotional and financial support. Over time, this responsibility can result in emotional distress, physical strain, financial burden, and social isolation. Part of recovery-oriented care includes supporting caregivers through education, psychoeducation programs, support groups, and respite services. When we support the family system, we support the patient. The recovery model shifts the focus from symptom elimination to meaningful living. Recovery does not necessarily mean cure. It means helping individuals build hopeful, purposeful lives, even if symptoms persist. SAMHSA defines recovery as a process through which individuals improve health and wellness, live a self-directed life, and strive to reach their full potential. Recovery is person-driven, culturally influenced, supported by relationships, grounded in hope, and based on respect. It recognizes the difference between clinical recovery, symptom stabilization, and personal recovery, which includes identity, empowerment, and meaning. Evidence-based interventions supporting recovery include CBT for psychosis, social skills training, family psychoeducation, supported employment through the IPS model, supported education, ACT, peer support, and cognitive remediation. The goal is independence, functional improvement, and improved quality of life. Nurses are essential members of the community mental health team, and much of our work centers on education. Education is not an afterthought, it is a core intervention. We help patients understand their diagnosis, the purpose of their medications, expected benefits, possible side effects, and the importance of adherence. We teach them how to recognize early warning signs of relapse, develop coping and social skills, strengthen self care routines, and create realistic crisis plans. We also support families, helping them understand symptom patterns, practice de escalation techniques, improve communication, and reduce expressed emotion in the home environment. When patients and families understand the illness, they feel less fearful and more prepared. Education promotes stability, reduces relapse, and strengthens shared decision making. It shifts individuals from being passive recipients of care to active participants in their recovery. Nurses advocate daily, often quietly but powerfully. Advocacy may involve coordinating across providers, addressing transportation or insurance barriers, connecting patients to housing and vocational resources, and ensuring that the patient's voice remains central in treatment planning. Advocacy also means protecting dignity and autonomy in systems that can feel overwhelming. Nurses bridge medical management and functional recovery. We monitor for extrapyramidal symptoms and metabolic complications. We assess adherence and identify barriers early. We coordinate follow-up care, collaborate with case managers and therapists, assess safety risks, and support transitions between inpatient and outpatient settings. Holistic care means addressing physical health, psychiatric stability, and functional goals simultaneously. Active case management is foundational in CMH. Case managers assist with appointments, housing, transportation, benefits enrollment, crisis planning, and linkage to employment and education. For individuals with the highest needs, assertive community treatment, ACT, provides intensive, team-based care with 24/7 availability, shared caseloads, and direct service in community settings. ACT reduces hospitalizations, improves engagement, and supports independent living. This coordination reduces hospital readmissions and promotes stabilization within the community. Community-based alternatives to hospitalization allow individuals to receive treatment in less restrictive environments while maintaining social supports. Nurses collaborate closely with these teams to promote continuity and prevent relapse. Individuals with serious mental illness face significant challenges navigating fragmented healthcare systems. Limited income, impaired executive functioning, stigma, and transportation barriers often interfere with consistent care. Medicaid eligibility determines access to CMH services, and resources may vary by county authority. Without structured support, medication non-adherence, relapse, and repeated hospitalizations become more likely. The CMH system exists to reduce these gaps, but navigating it can still be complex for patients and families. Consider a 24-year-old patient diagnosed with schizophrenia at age 19. He has had multiple hospitalizations due to medication non-adherence and cannabis use. He now lives at home with his mother, who works full-time and is experiencing caregiver burnout. He struggles with motivation, has limited social interaction, and feels discouraged about his future. Through the community mental health system, he is assigned a case manager and enrolled in outpatient psychiatric services. The nurse meets with him regularly to monitor medication response, assess for side effects, and provide education about the purpose of his antipsychotic medication. The nurse also teaches both the patient and his mother how to recognize early warning signs of relapse, such as sleep disruption and increased suspiciousness. The case manager assists with transportation and connects him to supported employment services. He begins part-time vocational training. His mother is referred to a family support group to reduce isolation and caregiver stress. He continues to experience occasional auditory hallucinations, but they are less distressing and no longer command him to act. He reports feeling more hopeful and more in control of his daily routine. Recovery in this case does not mean the complete absence of symptoms. It means improved functioning, greater independence, reduced hospitalizations, and restored dignity. This is the work of coordinated community mental health care, and nursing plays a central role in making it possible. Chronic mental illness requires long term, coordinated, community based care. The recovery model reminds us that individuals with SMI are more than diagnoses. Through education, advocacy, care coordination, safety monitoring, and collaboration with community resources, nurses play a central role in advancing recovery. For NCLEX preparation, remember, recovery is a process. Clinical and personal recovery are both important. Supported employment is highly effective. Family psychoeducation reduces relapse. ACT is for high need patients. Social determinants matter. Nurses are essential across the continuum. Our work does not end at stabilization. It continues in the community, where recovery truly takes shape.